This is Duncan Turner from the Vagina Doctor podcast. Welcome to the Consult With Me segment where we take a deeper look into our most frequently asked questions. But what do I know? I'm just a vagina doctor.
Okay, so let's today talk about urinary incontinence. There's so much to say. We get a lot of chit-chat about this all day, every day. But why don't you go into, there's a lot of confusion about the different types of urinary incontinence. So let's have you go into that.
There are basically two types. There's stress urinary incontinence, which occurs when there's increase in intra-abdominal stress, meaning from cough, sneeze, laughing, running downstairs, and a small amount of urine comes out, not a large amount. Then there is urgency incontinence, where somebody feels like they need to go and they just can't stop it. This is a circumstance when somebody's getting home, driving the car into the garage, they feel like they need to go, they're rushing towards the bathroom and they don't make it.
Right.
And that's usually a much higher volume. There are other types that there's an overactive bladder, which can cause incontinence. Just usually that would be the urgency type.
Okay, but wait, going back to the urgency when you're driving home and you have to pee and you get out of your car and you know the bathroom's closed. What is it about, if you had, an hour more to go, you could make it without peeing. But because you get home and you know the bathroom is close, you just start to pee. What is that?
Yeah, it's a matter of concentration to an extent. The emphasis on that person is to get into the bathroom, not to stop their bladder from contracting. The incontinence occurs when the intravesicular pressure is greater than the strength of the urethra, which is the bladder neck, to hold on to it. So if there's more pressure in the bladder and the muscles and support of the urethra aren't good enough, there'll be some leaking.
Okay. So sometimes I'm on a walk and I have to pee and I'm fine though until I get literally, 20 steps from the house.
Yeah.
So it really has to be.
It's a lack of concentration. Your concentration goes from one thing to another. If you were to stop at that point, stand still, you wouldn't pee. You'd have control over it. And that's what I say to patients that have urgency incontinence, that just stop.
Yeah.
And that sensation, that bladder spasm will go away. You can control it while you're there. And then you pick up and go on through.
Not with the house right there where you can see it. I feel like it's more complicated than that. It's more difficult.
I think you just need to try what I'm saying.
Okay.
And then you can say it doesn't
And
work.
when I pee in the walkway?
Yeah. Yeah, exactly.
Okay.
If you're trying to do anything else, so you're trying to, take the collars off the dogs because you brought them home with you, do other things, you're not going to concentrate on your bladder and then it can release.
Okay.
That's urgency incontinence. So part of it is bladder training. One of the things that happens is that all little girls are told to empty their bladder every time they think about it. Before they get in the car, before they do anything. Maybe little boys too, but particularly for girls. And they don't allow their bladder to expand. So the sensation of needing to go is because the bladder is getting full, or the person perceives it as getting full. And so if they can go longer times and stretch the bladder so they don't feel that, then they have better control over their bladder. So I think it's the wrong thing that we've been doing to tell little girls to go every time they think about it, because every time they think about it, they're going to want to go. And that can be every 15 minutes or hour or whatever.
But we've also been told that it's really bad to hold your pee.
It's not.
Yeah.
So,
Well, like us in the office, we, sometimes don't get a chance to pee all day because we're so busy.
Right.
And then there's other people that literally are peeing all day.
Yeah. Okay.
So
which of those two do you want to be?
I'm the one that doesn't get to pee all day.
Okay. And that's not a problem for you. So you're used to it, you do it. Now, there's a concern about not emptying your bladder completely, and then you're more likely to get an infection. But holding your urine during the day for a longer period of time isn't a problem. In fact, it's a good thing to have that bladder capacity. You're letting the bladder stretch, and then it will work when you want it to work. Some incontinence often occurs at night, or urinary frequency happens at night for people with an overactive bladder. But what happens a lot during the day is that people feel like they need to go, but they actually can sleep all the way. They can sleep all night without having to get up to go, or maybe they get up once if they've been drinking late at night, drinking any fluid. It's just a matter of bladder training a lot of the time, but then you can get a pathologically overactive bladder that you don't have control over. And that's a type of urgency incontinence. And again, the musculature of the bladder is stronger than the strength of the urethra to hold on to it. And people lose urine for that reason. There are medications that are used for that. Patients don't like those generally because they stop the neuromuscular reaction of nerve impulse to muscle action, which controls the bladder. Again, the contractions of the bladder being greater strength than the sphincter that's controlling things. And so patients don't like the medications because they have a lot of side effects. They affect other neuromuscular activities in the body. And they get dry eyes, dry mouth, feel miserable. The medications don't seem to work right away, and they take a few weeks to be beneficial to patients. And the side effects generally cause patients to stop taking the medication and not deal with it. I'll talk about another treatment for that in a moment, but if we look then at urinary stress incontinence, about 50% of women after childbirth will experience some stress incontinence. That's leaking, when they cough, sneeze, laugh, run downstairs.
Right. Those are the women that have just had babies, and those are the calls we get for people like, I can't jump on the trampoline with my daughter. And
trampoline's not a fair test to anybody. You shouldn't expect to pass that.
Well, we hear that, or I can't run anymore. That's the other common one we hear.
Yeah. But the same thing happens at menopause. And whereas after childbirth, it's because everything's been stretched, particularly if it's been a vaginal delivery. But with it also is because of lower estrogen levels after childbirth, particularly if somebody is breastfeeding. Similar thing happens to patients in menopause. The estrogen levels in the pelvis are much, much lower. The tissues aren't as strong. So then they start to get this urinary stress incontinence, and it reminds them of what it was like after they had kids. But it's the same thing happening for similar reasons. And that can sometimes just be treated with vaginal estrogen to strengthen the tissues.
And that's a suppository.
Again, yes, suppository, cream, little pill, the number of different productions for it.
And then we have a couple of procedures in the office that work. A lot of the time they work, but you do have to keep doing them every year.
The more traditional approach, and most of the time with stress incontinence, the state of the standard of care is to put a sling under the urethra to hold it in place. It doesn't compress the urethra. It doesn't kink it. It just keeps it in place so that when there is that movement, increased pressure in the abdomen, the cough or the sneeze, etc., this little sling will hold it in place. It won't move. And that movement, if the sling wasn't there, is what causes people to have the incontinence. The angles don't stay the same. So that's the traditional treatment. Since 2016, we've had some other rejuvenation type procedures to the vagina. Started off with a laser. And we were actually using the laser for different indications for vaginal dryness and so on, but we found that patients' urinary symptoms improved as well. And then we discovered that radiofrequency energy to the pelvis really was better than the laser. And now we've gone to the extent, and this sounds terrible, but it's actually a pretty comfortable procedure, is microneedling of the vaginal mucosa with radiofrequency.
Is this because those procedures thicken the area to then help better support the urethra?
Yeah.
Is that why?
That's primarily why. But it's also been found to help patients with the urgency incontinence and an overactive bladder, which was a surprise. So we have a lot of different things now to help all of these patients in one way or another. The microneedling is the best non-surgical, non-invasive treatment, which is very effective. I've done a lot of slings for urinary incontinence, but I'm doing far, far fewer now since we've had this technology. And that's always been the recommendation. Since we've had it, it's always been the recommendation to the patients to try that first, because not only may it resolve the problem and them not need surgery, but if they do need surgery, the tissues are stronger and will heal better. So it's a win-win.
Thanks for listening. And if you have more questions, please let us know, either by email or DM us on the Vagina Doctor podcast.
See you in the next episode. The Vagina Doctor podcast. It all starts here.